Good afternoon. Let us start. It is my honor. Ready? Okay. So it is my pleasure and honor to introduce my Professor EHAB WAFA. Professor EHAB WAFA is a senior professor of nephrology and dialysis and transplantation in the center, and he was the past president of the unit. We learned from Professor EHAB a lot regarding knowledge, attitude, and skills. And today, Professor EHAB will give us a talk different from the scenarios that we discussed about a modality which is very important for you to know some idea about it, which is plasmapharesis. Professor EHAB.
Thank you, Professor Hussein, for this nice introduction. Regarding apharesis, the broad term for manipulating plasma therapy. At first, plasma exchange came into widespread clinical use after early reports of beneficial effect in good muscle syndrome in mid-70s. It's used to remove many large molecular weight substances from plasma, including pathogenic antibodies, cryoglobulins, like proteins. We have newer techniques that allow more selective removal of plasma component, such as double filtration plasmapharesis, cryofiltration, and immune absorption, and the newly introduced nanotechnology in the field of plasma exchange. Apharesis include all these categories. It includes leukocytopharesis, extracorporeal photopharesis, platelet apharesis, thrombocytopharesis, erythrocytopharesis, red cell exchange, plasmapharesis, LDL apharesis, and at last, plasma exchange. I have to stress on one point in this slide, that plasma exchange is different from plasmapharesis. They are not the same thing. Plasmapharesis is a procedure that we remove only small amount of plasma for the purpose of preparation of vaccine or transfusion for a boy, a child, with no replacement for the donor. But in plasma exchange, it's a procedure where large volume of plasma is taken from the donor or from the patient, and it's about 1.5 plasma volume, and they should be replaced by a replacement. This is the difference. However, the other indications are under the term apharesis. We have leukocytopharesis for treatment of acute leukemia and for collection of hemopoietic progenitor cell. We have extracorporeal photopharesis for the purpose of immune modulation. We have platelet apharesis for transfusion, platelet transfusion, thrombocytopharesis for treatment of thrombocythemia, erythrocytopharesis, that's to take blood from the donor and remove to produce RBCs to take, just to prepare RBCs for transfusion. Red cell exchange, as in case of falciparum malaria, to take out hemolyzed red cells and give the patient normal cells. And LDL apharesis just to remove LDL. This in clinical practice, this figure summarizes red cell apharesis is used most commonly in sickle cell disease and malaria, white cell in leukemia and cell therapy, platelet for cases of thrombocytosis, and plasma for different indications as TTP, Guillain-Barré, myasthenia gravis, partial syndrome, or macroglobinemias. We have two techniques, two main techniques, centrifugal technique and the whole fiber technique. Regarding the centrifugal technique, using centrifugal technique for plasmapharesis, this machine allows withdrawal of plasma from either synchronous or intermittent return of blood to the patient. No upper limit for the molecular weight to be removed, and the blood flow is from 90 to 150, and platelet count can decrease down to 50%. This is a machine of centrifugal cell separator for plasma exchange. It is commonly done by the hematologist. Here, blood is pumped from the patient and then to the centrifuge. Plasma is separated and collected, and red cells are reconstructed and returned back to the blood. The membrane plasma filtration uses highly permeable hollow fiber with membrane pores from 0.2 to 0.5 milliangstrom. All immunoglobulins will cross the membrane. IgG more efficiently removed than IgM. And large immune complexes and the cryoglobulins may not be adequately cleared. Many membranes allow clearance of molecule up to 3 milliandalton, and there is no loss of liquid. Regarding the hollow fiber filtration, second modality, here blood is pumped out for the patient, go to the hollow fiber, plasma is separated and pumped out, and the red cells are reconstructed by colloid and returned back, heated and returned back to the patient. Membrane plasma filtration, hemolysis carbon care, if the transmembrane pressure is too high, blood flow rate from 90 to 200, and membrane used here are polysulfone, polyacrylonitrile membrane. The absorptive properties of the membrane for cytokines and the other biomolecules may account for some of the beneficial effect of plasma filtration. Here, this curve is showing that transferrin, due to its low molecular weight, is first to be removed, and it's followed by other molecules as IgM and according to molecular weight IgM and IgG. These are the molecular weight of substances to be removed. We have the blood-brain hydrogen, creatinine, beta-2 microglobulins, and then up to albumin, IgG, and IgM. The first category is removed the small molecular weight is removed by normal hemodialysis, and then the middle molecule are removed by hemodifiltration, and then large molecules are removed by therapeutic plasma exchange. The third modality for apheresis is immune adsorption. Protein A immune adsorption. It removes immunoglobulin alone from plasma without the need for replacement fluid. This is the difference. And without depletion of clotting factor or compound. Protein A selectively binds the FC domain of the immunoglobulin molecule. The immune adsorptive column can be repeatedly regenerating, and the column has been used for 1 year, I think, up to 30 occasions. Just I want to stop. Are you following me? No problem? Huh? Oh, huh? This is the machine. Blood is pumped from the patient, goes to the hollow fiber plasma filter. Plasma is separated and pumped to the columns, and selectively the columns bind the immunoglobulin and get it out. And the blood is reconstructed and heated and go back to the patient. This is not one type of column, it's different types according to the immunoglobulin we want to remove. This is a column, up to 30 times per patient. The fourth modality is double filtration plasmapharesis, what's called as cascade filtration. It's used to separate cells from plasma, and then secondary plasma filtration with a small pore to remove plasma solids based on the molecular size. Most albumin return back to the patient together with lower molecular weight protein. This is schematic. Here is the filter number 1, where plasma is separated, and then the blood returns back to the patient, and then the plasma go to another filter of fine pores. This is the hollow fiber. This is the hollow fiber. The small molecule only can pass. This is from the first filter. This is the component of the blood. Plasma here pass with a relatively large molecular weight substances. This is the filter of the plasma. And it passes to the next filter. Here, the next filter, this the small, very fine pores, the small molecules can pass on, and this can go to the patient. But the large molecules are removed as a waste. The molecules inside the whole fiber are removed as a waste. But the filtrate only return to the patient. This waste is mainly containing immunoglobulins, immune complexes, and LDL cholesterol. The need for plasma albumin transfusion is greatly reduced, and we can use heparin, commonly heparin. Now to the up-to-date technology for apheresis, that's the hemophilex technology for nanofiltration. This is a modern technology that allows the dialysis membrane to spore up from 20 nanometer to 100 nanometer. One example of this membrane is trachylated membrane, special membrane obtained from interaction between polymer film and ions accelerated in charged particle accelerator. That is, the membrane is exposed to beta irradiation that creates pores and channels inside the membrane. This is the pores, and this is the channels. And this is a machine very recently designed for hemophilex nanofiltration. Blood plasma filtration machine whose filtering elements are produced using thread-acted membrane with pores from 20 to 100 nanometer in diameter. The advantage of hemophilex nanofiltration, it allows performing the treatment with single and a small needle with reduced extracorporeal volume. It has low priming and short volume and short duration of treatment, and the exchange of low volumes allow not to use plasma as replacement fluid, so reduce the risk of infection and allergy. And it can be comparable or even superior to traditional plasma exchange because it's more tolerable and less invasive. It is used in refractory cases as some cases of lupus and vasculitis. Primary membrane was invented for use in vaccine preparation in Moscow, and then the use has been transferred to the field of nephrology. As previously said, the diseases treated by therapeutic plasma exchange, mainly a very good part is from neurology, Guillain-Barré syndrome, myasthenia gravis, and other from nephrology as cryoglobulinemia, antipleural basement membrane disease, post-immune rapidly progressive glomerulonephritis, lupus, myeloma, recurrent FSGS after transplantation, and in cases with FSGS also. According to the American Society of Apheresis, they have categorized the indications for plasmapharesis into four categories. The first category where apheresis is absolutely indicated, no contraindication. The second, in which it should not be done alone, should be given in combination with other modality, cyclophosphamide, rituximab, immune suppression. The third category, where apheresis as an optimum line of treatment is not well established, and we should take a decision for every case individualized. The fourth category, where apheresis can be ineffective or harmful, and we have to follow the departmental policy for use of apheresis in this class. We have renal indication for plasma exchange. We have to know class 1 renal indications. ANCA-associated rapidly progressive glomerulonephritis, antipleural basement membrane disease, this is in nephrology, cryoglobulinemia, focal segmental glomerulosclerosis, atypical hemolytic uremic syndrome, and in kidney transplant. And this will be explained in more detail in the next slides. And some TTP and in drug-associated thrombotic microangiopathy. Regarding manipulating patients with this diagnosis, the duration of treatment should not be less than 2 weeks. Exchange volume, 50 milliliter per kilo in classic plasma exchange. Replacement fluid will in all with alcohol except TTP and and regarding immune suppression, it's indicated in the first three categories and none in the next two as recurrent FSGS and hemolytic syndrome. In antipleural basement membrane antibody disease, it's called plasma exchange removes antipleural basement membrane antibodies effectively. And the antibody synthesis is initiated by is inhibited by concurrent use. Okay. So I remove the antibodies and prevent further formation by cyclophosphamide or corticosteroids, 70 to 90% of patients now survive, and the patient plasma exchange with daily 4 liter should be done initially for 14 days. Pulmonary hemorrhage, whenever you have pulmonary hemorrhage, you have to go immediately to plasma exchange. It's an independent indication. Independent means an absolute indication without thinking. You have to go for plasma exchange. In patients with a small vessel vasculitis with severe renal failure, especially with going up serum creatinine, or a patient with dialysis dependency, or who have pulmonary hemorrhage. These are the indication in cases of small vessel vasculitis. However, it can be used in other crescentic glomerulonephritis, as post-infectious glomerulonephritis. Glomerulonephritis with infected endocarditis, associated infected endocarditis, IgA nephropathy, membranoproliferative glomerulonephritis, and membranous nephropathy. No good evidence for any benefit in rapidly progressive glomerulonephritis due to antiglomerular basement membrane disease or vasculitis. However, it can be beneficial in some cases. It is reserved for IgA nephropathy and glomerulonephritis with rapidly deteriorating kidney function and the extensive fresh cellular crescents in the biopsy specimen. Focal segmental glomerulosclerosis, we can do plasma exchange or protein A immune absorption in cases with primary FSGS or recurrent disease after transplantation. However, plasma exchange is not so recommended in primary FSGS. No controlled trials for plasma exchange treatment in recurrent FSGS, no randomized prospective controlled trial done till now. In hemolytic uremic syndrome, we have 2 categories: diarrhea negative HUS and diarrhea positive. In diarrhea negative HUS, no controlled trials has been done in childhood hemolytic uremic syndrome and in adult diarrhea positive HUS. But it's uncontrolled observation that suggests possible benefit. In thrombocytopenic purpura, fresh frozen plasma together with plasma exchange replenish von Willebrand cleaving protease admin13 and remove the antibodies against it, and to remove a large von Willebrand factor multimer from circulation. In hemolytic uremic syndrome, plasma exchange is used in all adult STTP and diarrhea negative HUS, and perform all exchanges against fresh frozen plasma or cryopore fresh frozen plasma. Removal of autoantibodies to von Willebrand multimer cleaving enzyme and or infusion of von Willebrand multimer cleaving enzyme. In lupus, we have to stop a little bit at this point because it's a critical point. No benefit from plasma exchange over conventional immune suppression for renal, serological, or clinical outcome on the short or long term. However, plasma exchange may be beneficial in patients with crescentic lupus, pulmonary hemorrhage, cerebral lupus, catastrophic antiphospholipid syndromes, and lupus associated with TTP, or lupus non-responsive to conventional treatment. Patients for whom cytotoxic therapy has been withdrawn because of bone marrow suppression or other things. I will show you 4 in-depth reviews. The first one published in 2009 in Lupus Journal, Beyond Immune Suppression Challenge in the Clinical Management of Lupus. They concluded that plasmapharesis, plasma exchange, has no role in lupus. The second, review article published in Autoimmunity Reviews Journal. It's a critical in-depth review. They found it useless. The third one, published in Best Practice in Research Clinical Rheumatology 2013, Current Management of Lupus. They found loop plasma exchange of doubtful value in lupus. The fourth one, November 2014, treatment of severe lupus with a new horizon. They found it useless. So how can we solve this problem? This is a randomized controlled prospective study done to compare plasma exchange with immune adsorption. Can one of these techniques solve the problem in lupus? Maybe. It was a randomized controlled trial comparing the efficacy of standard of care combined with plasma exchange against the standard of care alone in patients with lupus. Beneficial effects has been reported in patients with refractory disease course and in pregnancy with prior complications due to lupus and antiphospholipid syndrome. This is clinical presentation showing the effect of immune absorption and plasma exchange. You can find that in immune absorption, they can specifically remove IgG, including disease-specific immunoglobulins as anti-DNA, ANA, and phospholipid antibodies. It can decrease the level of ANA and anti-carbolipine antibodies and lupus anticoagulant. In plasma exchange, it will deplete most of the plasma proteins, including immunoglobulins, coagulation component, but also disease-specific antibodies as anti-DNA, anti-nuclear factor, and phospholipid antibodies. So they attain the same target, nearly the same target. As they concluded that immune absorption seems to have beneficial effect in patients with refractory lupus and in cases having contraindication to standard immune suppression or during pregnancy. The mechanism of immune absorption relates to auto-antibody removal by the plasma exchange removal of activator complement component, coagulation factor, cytokines, and microparticles. Both treated forms have good safety profile, and there is a need to more clearly define the clinical utility of plasma exchange and immune absorption in refractory lupus and antiphospholipid subgroups. There is a clear need to perform randomized controlled trial to evaluate efficacy, safety, tolerability of both treatment. Now we shift to the point of cryoglobulinemia. Type 1 cryoglobulinemia usually is associated with myeloma or lymphoma. Now, monoclonal immunoglobulins cause hyperviscosity and cryoprecipitation. They can be easily removed by plasma exchange with immediate clinical benefit. Why? Because this immunoglobulin is of the IgM type, high weight. It can be separated by either techniques, any technique, plasma exchange. And what's interesting at this point is that there is a slow rate of reformation. So with single or two sessions, the patient with active lesions rapidly improves. Because the rate of reformation of IgM is very slow, so the patient recovery is marked. In type 2, mixed essential cryoglobulinemia, those associated with lymphoma and HCV, monoclonal antibody اللي هو IgM type with specificity for second and usually polyclonal immunoglobulin. The result of immune complexes can be deposited in the microcirculation and particularly associated with mesangial proliferative glomerulonephritis, causing fingerprints, if you remember, in mesangial proliferative glomerulonephritis. The resulting immune complexes can be deposited in the microcirculation and is associated with plasma exchange is effective in clearing immune complexes. The arthritis, skin lesion, and digital necrosis resolve with plasma exchange. Patients with rapidly progressive glomerulonephritis can recover renal function if the cause is cryoglobulinemia. Cytotoxic agents or rituximab, it prevents the resynthesis of cryoproteins. Long-term intermittent plasma exchange to control symptoms. Till now, are following me or something different? Huh? Okay? Can I continue? I should know that if they are not following me, so what? The subject is difficult, but interesting.
Five minutes. 5 minutes. 5 minutes.
We are near to finish. In ANCA-associated glomerulonephritis, the results of clinical trials of apheresis therapies, either plasmapharesis or cyclopharesis, in ANCA-associated vasculitis are disappointing. The results showed no benefit. Benefits just in dialysis-dependent patients and in preserving renal function. In contrast to ANCA-associated vasculitis, in antipleural basement membrane rapid glomerulonephritis, the beneficial effect of plasma exchange has been well established. It may be attributable to the direct role of antipleural basement antibody in the pathogenesis of anti-GM antibody rapidly progressive glomerulonephritis. While ANCA-associated vasculitis, no direct role for ANCA has been established. Reports from the European Community Group suggest that adding plasma exchange to immune suppressive therapy was not beneficial if there was severe tubular atrophy and if the surviving glomeruli are less than 33%. Japan nationwide survey of rapidly progressive glomerulonephritis recommends cyclopharesis in patients with aggressive form of rapidly progressive glomerulonephritis with rapid deterioration of renal function, like P3 ANCA-associated rapid progressive glomerulonephritis or pulmonary renal syndrome complicated by severe inflammation or relapse from high LPO ANCA type 3. These are studies showing little or no benefit in cases of ANCA-associated glomerulonephritis. In myeloma, the plasma exchange has benefit in myeloma with either cast nephropathy or light chain renal toxicity. Plasma exchange should be reserved for patients with high light chain load and cast nephropathy on biopsy. In transplantation, it's useful in antibody-mediated rejection to remove the immunoglobulins. However, no convincing evidence that plasma exchange has any role in treatment of chronic rejection. Anti-HLA antibodies, we can use plasma exchange and immune absorption to remove these cytotoxic antibodies before transplantation as preparation in hypersensitized patients. In addition to cyclophosphamide, and this can lead to better graft survival. Also in incompatible blood transfusion, ABO incompatible blood transfusion, we can use also plasma exchange just to remove antibodies against blood groups. In recurrent FSGS after transplantation, we can use plasma exchange or double filtration, protein immune absorption to treat recurrence of FSGS, and this can lead to persistent remission. Plasma exchange also, few minutes, it can remove many, has the value of removal of many drugs as basiliximab, cefotriaxone, cefotaxime, chloramphenicol, IVIG, alpha interferon, propranolol, rituximab. This can be removed by plasma exchange. All immune suppression as rituximab, IVIG, thymoglobulin, eculizumab are removed. However, prednisolone and cyclophosphamide can be removed or partially removed by plasma exchange. In neurology, as I mentioned, it was found that in neurology indication, which is very important in acute inflammatory demyelinating polyneuropathy and chronic inflammatory demyelinating polyneuropathies are class 1 asthma. Also in polyneuropathy with monoclonal gammopathy, in myasthenia gravis, and in chronic or secondary aggressive multiple sclerosis, and in Sydenham, Korea, and sometimes in compulsive obsessive neurosis. This is myasthenia gravis where persistence of acetylcholine as a receptor due to antibodies against choline esterase lead to muscle fatigue. This myasthenia gravis plasmapheresis can be done for acute myasthenic crisis, respiratory insufficiency, or failure to respond to medications and or side effects to medication, and before and after thymectomy. This is before plasmapheresis, and then muscle fatigue is removed by removal of the antibodies with plasma exchange. Complications of plasma exchange: hypotension, citrate intolerance, transmission of infectious disease, and risk of bleeding, dilution, and hypokalemia. And these are, ASPA has published the important side effects of plasma exchange in terms of paresthesia, urticaria, hypofibrinogenemia, hypotension, nausea and vomiting, and gastrointestinal infection and pneumothorax. The last point is red cell exchange in sickle cell disease. We have to remove the hemoglobin S. We have to keep it below 30%. So that we can avoid infarcts or organ infarcts, pain crisis, priapism, and acute chest syndrome. In malaria, especially Plasmodium falciparum, we can replace the red cells with a newer one, and we can also remove cytotoxins and prevent lactic acidosis and hypoglycemia. Remove cytokines. And then leukophoresis in acute and chronic myelogenous leukemias, because hyperviscosity is an important clinical manifestation causing CNS symptoms, hemorrhage, and pulmonary insufficiency. You have to combine chemotherapy with leukophoresis, and this is ASPA category 1. Platelet apheresis, we have to use plasmapheresis in combination with chemotherapy, and is also ASPA grade 1. In conclusion, early introduction of plasma exchange appeared to be effective for various immunologic kidney disease. However, plasma exchange primarily serves as an adjunct to other immune suppressive therapies and is often expected to have beneficial role. Early diagnosis and treatment of the underlying condition remain important. The strongest evidence for plasma exchange is for thrombotic microangiopathy, in which it serves as a single most important therapy in most cases. Further research is necessary to establish the optimum dose, frequency of therapeutic plasma exchange, and appropriate replacement fluid, and the plasma product composition for each condition. We have future direction. The new innovation of hemophinex nanofiltration using track-acted membrane may solve the problem of resistance in selected and refractory cases and offer superior outcome to traditional plasmapheresis. Thank you.
Thank you very much, Professor Ehab, for this excellent and comprehensive overview about plasmapheresis. Now we have time for two questions. Yes. First.
Thank you, Professor, for your presentation. I have a question about for the plasma exchange. First of all, I want to say that this practice is not common in our countries, but within the school. The challenge we had when I studied, it was to reduce the volume of plasma the volume of replacement fluid, plasma or albumin, because it's very expensive. I'd like to ask that there is now a group which is working on that.
So you have plasma flux, but the problem is to use albumin or plasma.
Yeah, but the problem.
And you used plasma.
Plasma.
Because it's available.
Yeah, but it's very expensive. So, if there is needed 4 liters, now is there a group which is working to reduce that volume of fluid replacement, or we still working with the same volume? That is the question.
Your question is not clear. Do you ask if the patient is overloaded and you would like to do plasma exchange, and instead of doing, for example, giving 4 liters to give 3 liters and do flux him, or to have plasma filtration 4 liters?
My question is, the challenge in this plasma exchange is to reduce the volume of replacement liquid.
I understand the question. Does one of the aims of plasma exchange is to reduce plasma volume?
No. There is a role of ultrafiltration. Another point. But plasma exchange will remove volume and replace it with another volume.
Yeah. It's not to reduce the volume of the liquid because the patient is overloaded. No. But the replacement volume, because you remove a certain volume of plasma and then you have to replace. So, but the challenge is now, because we used 4 liters, we remove 4 liters and then you have to replace with 4 liters. And
then remove and replace same volume.
Yeah.
If you want to reduce extracellular volume, you can proceed for ultrafiltration. Or you can give a little volume of replacement fluid, 1 liter less. Okay, can be. But we don't do that because the target is to remove complexes. The target is to remove antibodies. The target is not to correct the fluid balance.
Because this is one of the faults that you find a resident saying that the patient is overloaded. So instead of giving him 4 liters, we give him 3 liters, and we have ultrafiltrated plasma flux, plasma filtration 4 liters. This is not a safe business. So the idea is drop by drop. You filter plasma and give plasma or physiological albumin. Physiological albumin infusion or exchange is albumin 4% or 5%. That's what we do. So we have albumin 20%, and then we add it to the saline. At the end of the day, we are conservative. So we use albumin 5%, but you can use albumin down to 4%. And you should continue 1 milli over 1 milli. So 1 milli plasma filtration and giving exchange 1 milli of albumin 4% or 5%. Okay. It seems that there is a problem in understanding, and we can continue after lunch. After dinner.
Because
we have to look for the target of the therapy. The target is to manipulate the immune system, not to hold replacement. But however, you can do it. You can take 4 liters, and is it only with 3 liters? You can do it, but it is not feasible.
Dr. Nagy, do you like to comment?
We
you don't do that except if there is hyperviscosity syndrome
Yes.
due to plasma problem, like in some few cases of multiple myeloma or Wagner-Strom. Wagner-Strom is a lot of IgM in the blood. In these cases, when you remove it, you don't replace the whole bunch of plasma protein, but you can here use 4% or a little bit lower concentration of albumin. But the aim is not to get rid of volume, but the aim is to get rid of some innocuous problem inside the plasma. Whether it's antibodies or toxins or whatever. You are removing something inside the plasma, but you are not removing the plasma itself. Is this work?
See, it doesn't work. So, the last question. The last. You have a question? Yeah. Okay. Okay.
Thank you very much.
Do you see me while we have photos for you while you are asking? Because on Thursday I reviewed the photos and I give gifts for the best interactors.
Thank you very much, Professor, for the presentation itself here. Back at home in Zambia, we have some experience with plasma exchange itself here. We used it effectively with patients in ICU, the Guillain-Barré syndrome itself, quite effective here. Also, we have used it in those patients that we are preparing for transplant because at home erythropoietin is very expensive. So we have been failing to maintain the hemoglobin at 10 or something like that. So in most cases, when somebody is ready for transplant, these are patients who have received multiple blood transfusion. So I'll be using this, I don't know if it's advisable itself, combination of plasma exchanges as a prerequisite part of the preparation for patients with transplant. Now, using a mouth filtrate machine, which comes with a big budget. Now, my question is this: on your presentation itself, one of the indications for plasma exchange was also focal segmental glomerulosclerosis. Now, in HIV-associated nephropathy, we have focal segmental glomerulosclerosis collapsing type, and we have on two occasions trying to use plasma exchanges for those patients who have HIV-associated nephropathy, which
Can be given, it can be done in focal. If it's just after transplantation,
yeah,
you can have a good percentage of cure and remission of cure, as I have said in the slide. And if it's just after transplantation.
but this the FSG, the collapsing type, focal segmental glomerulosclerosis, they can be used.
But the collapsing type of focal and segmental glomerulosclerosis is, you can consider it as very severe form. And I'm not expecting that plasmapheresis will add anything to these patients. I can spell plasma exchange for preparing these patients who has idiopathic collapsing type for transplantation. Because this is our protocol here. Before transplantation, we do plasma exchange to remove the presumed circulating factors, and after transplantation, if proteinuria recur, the earlier initiation of plasma exchange is recommended. So this is our perspectives here for the indication of plasma exchange with focal and segmental glomerulosclerosis to prepare the patient for transplantation and to manage the recurring FSGS after transplantation.
This type of lesion have progressive course. We avoid transplanting this class of patients because of the patient from the time to end the stage is very short, and so this will recur also after transplantation in the same way. So we have to avoid this one regarding transplantation.
We can delay, but some centers avoid. But here we delay the process of transplantation until there is no proteinuria.
It's very important to see the time of disease recurrence to the end stage. How much time? If it's very short, so the prognosis after transplant will be not good. You have to avoid this diagnosis as far as you can.
So thank you very much, Professor Ehab, for your presentation. So it's time for the last presentation. And the last presentation, always Professor Naga Abdelhadi has a